Today we're going to talk about therapeutic communication. Communication is the process of exchanging information and generating and transmitting meanings between two or more people. The message can be verbal or nonverbal. So verbal communication is spoken or written words, and nonverbal communication is communication without using words. So you may use your facial expression, body movement, eye contact, etc. And on the next slide, we'll speak more in depth about nonverbal communication. So nonverbal communication begins on page 175, continues into page 178. So it may include touch, eye contact, facial expression, posture, gait, gestures, appearance, sound, and that's just like moaning or groaning or crying, right? No verbal words or silence. And the mode of dress or grooming can also be a form of nonverbal communication. Communication through technology. Electronic communication includes internet and social media websites. It can be challenging for nurses to protect the privacy of patients with such easy access to the internet. Social media is a web-based platform used for communication where people share and participate in dialogue. The National Council, State Board of Nursing, and the American Nursing Association has issued guidelines for RNs regarding social media usage in regards to patient care and confidentiality. Email and text messages are a good way to communicate through staff members, but privacy can still be an issue. And each facility has its own policy in reference to communication via email and text messages. Usually it has to be secured, so it must be the company's equipment. However, follow your facility's policy. Telehealth and telemedicine are used as virtual technologies that allow both verbal and nonverbal communication between the clinician and the patient. So factors influencing communication, you can find this on page 181 to 183. So developmental levels, social cultural differences, roles and responsibilities, territory and space, physical, mental, and emotional state, values, environment. These all can influence your patient's communication. Therapeutic communication is patient-centered communication. This is when the nurse helps the patient explore their thoughts, feelings, and express themselves. And also the nurse avoids barriers that will hinder therapeutic communication or that will take away the focus of the patient in the conversation. So the goal is to promote an understanding of the patient's feelings and to build a rapport and trust while maintaining professional boundaries. So what it is not, or non-therapeutic techniques. A nurse should never ask the question why to a patient. That will put the patient in the defensive mode and they will be unable to receive from you. And the establishment of trust and building rapport are sabotaged. You never want to give your opinion. Your opinion does not matter. False reassurance. You never want to give the patient false reassurance and explain to them everything will be okay, it will all work out. That is non-therapeutic and sometimes untrue. You never want to give closed-ended questions unless it's on a specific topic in an assessment such as do you have pain, and then you can lead further with the other interview questions in reference to pain to gather that information. But closed-ended questions are non-therapeutic and usually are not beneficial because they give you a yes or no answer. So do you have pain? Yes or no. Changing the topic or avoiding a difficult topic is non-therapeutic. If the patient brings up a topic that you're uncomfortable with, just be there, be present, listen, allow them to express their thoughts. Minimizing the patient's thoughts and feelings is also non-therapeutic and will put the patient on a defense and they will be unable to receive from you. Judging a patient is non-therapeutic. Failing to remain patient-centered or focused is non-therapeutic. So the nurse should never refocus the conversation solely on them. There is a technique where you will share of self, but you will refocus back to the client immediately. Do not take over the conversation and explain your situation when the client is trying to share their personal feelings. So let's continue to talk about non-therapeutic techniques. So recognizing the client is a person and it's not just a diagnosis. So the nurse must be focused on the whole person, not merely the person's diagnosis. So there is a whole being and we must acknowledge that. In addition to that, you want to address people by their formal name, so Miss, Mr., unless otherwise directed to do so. So failure to listen to your patient can be a hindrance as well. Failure to listen to cues in your patient's response and conversation can occur from a lack of concentration on what the patient is saying. So not actively listening and not being actively present, you will miss those cues where the patient is giving you signals that they may need a moment, they may need you to come back, right? Or they're not ready to communicate openly at this moment. So often these signals indicate the readiness to talk or not talk, okay? So another non-therapeutic technique is using cliches. So we already know false reassurance is a no-no. So we're never going to say something like everything will be all right. But stay away from other cliches as well, like cheer up, tomorrow's another day. It's only up from here. Don't worry, you'll just be fine in another day or two. So we don't want to minimize what they're going through, and we do not want to provide false reassurance because we can't guarantee that patient's outcome. Hope that made sense. Probing for information. So you want to, again, follow the patient's leads, right? Because if they feel like you're probing for information or you're giving them the third degree, they are going to shut down. They are not going to want to talk to you. So sometimes questions are necessary to be answered, but again, follow the patient's lead. You may need to reintroduce the topic at a later time after a patient got some rest or after a patient has something to eat or whatever may be the priority for that particular patient. So letting the patient take the initiative allows you to divulge more deeply at a time when a patient is ready. And the patient has to be ready and willing to talk to you. All right, so then I also have rumors and gossip. So gossip and rumors are a common form of communication, particularly in healthcare settings, sometimes referred to as the grapevine. Gossip and rumors can produce detrimental effects on the relationship and group building. So you want to avoid gossip and rumors. You don't want to come in talking about other staff members. You don't want to engage unless the patient is reporting something that was neglectful or a violation of the patient's rights. You don't want to engage in any he said, she said, or gossip like behaviors in regards to your colleagues or even other patients. All right, so on page 201, it talks about responses to disruptive behavior and communication. So incivility and bullying is considered a disruptive behavior. I'm sorry, that's on page 200 and it goes into page 201. So incivility and bullying, that should not be tolerated by the nurse or by the patient. So no one deserves to be bullied or harassed, right? So there has to be a mutual respect from both parties. Okay, incivility is rude, disruptive, intimidating, undesired verbal or nonverbal communication and behaviors. And anger and aggressive behaviors between nurse to nurse. Um, Hostility has been labeled as horizontal violence, and its negative behavior is also considered bullying or lateral violence, and is professional incivility. So that's not tolerated in the workplace and should not be displayed. However, as a nurse, you do not have to be bullied as well. So we know that sometimes our patients are not so nice. However, there's boundaries and limits, and no one has to accept abuse. Verbal and physical aggression. So, like I said, sometimes your patients are not the nicest and they're not as appreciative as we would expect or like. However, we cannot become verbally or physically aggressive with the patients, regardless of how they're acting. Aggression in healthcare setting can take many forms and occur in for numerous reasons. So, workplace violence is defined as a violent act including physical assault and threats of assault directed toward persons at work and on duty. So, the nurse must remain respectful and professional. There are several therapeutic techniques. Open-ended questions is when the nurse gives the patient a question that requires explanation. So can you tell me why you feel that way? And this will require the patient to take lead of the conversation and to express their feelings. Restating is repeating the patient's exact words. Reflecting is returning the focus to the patient's situation. Paraphrasing, restating what the patient said in their own words. This conveys understanding of what was expressed to you. Exploring is gathering more information from the patient about what they may have mentioned, but not have went in depth about that particular topic. Focus questions collects data and encourages feedback. It also clarifies the patient's ideas. General leads allows the patient to take the conversation and go where they desire. We do not want to influence their disclosure. Present reality, dispelling delusional beliefs, misconceptions, and hallucinations. Reorientating the patient to reality, basically. Offering of self, Limit, limited self-disclosure with a quick return of the focus to the patient. So you never want to take the conversation and turn it into something that's totally about you, but you may want to share a brief history to say, I've been there and I'm here for you if in fact you need me, because I do have some understanding of how you're feeling. Nonverbal and verbal actions must be congruent. So you cannot say, I'm there with you, I broke my foot, I felt that pain, I felt that agony, I felt that debilitating, um, dependent state. But your actions show, your nonverbal actions show that you are frustrated with helping this patient every time she has to go to the bathroom, walk to the bathroom. So your verbal and your nonverbal must match. And there are 3 others that I will review on 3 other slides. These are very common use techniques. One is active listening, very important. Silence, which is important in certain situations, and providing leads. So we'll talk about them on the next few slides. So on the previous slide, it talked about therapeutic communication techniques. That is the same thing as proper interviewing therapeutic techniques. Okay, so this goes along with the previous slide. However, in close-ended questions, sometimes they are necessary. For example, are you in pain? Yes or no, right? However, we prefer open-ended questions when we can use them to allow the patient to continue to engage in conversation and not to shut down the conversation. But closed-ended questions are necessary at times to get the information you need, right? So closed-ended questions are used to gather specific information from a patient to allow the nurse and the patient to focus on a particular area. Closed-ended questions are often a barrier to effective communication. However, sometimes they are necessary, okay? Moving along. So validating question and comment. So this type of question is a comment that serves to validate what the nurse believes they heard or observed. So overusing validating questions and comments might lead the patient to think the nurse is not listening. However, to continue using validating questions will allow them to make sure that they heard the patient properly, right? And that they are receiving the information that the patient conveyed. Sequencing questions and comments. Sequencing is used to place events in a chronological order or to investigate a possible cause and effect relationship between events. All right, and you can find all 3 of these on page 196. Active listening is another therapeutic communication technique. SOLAR is an acronym that describes the proper way to apply this technique when interacting with your patients. So you want to always be at eye level. So the suggestion is to sit facing the client so that you are not standing above them and hovering over them, but you are at eye level with the client. You want to observe an open posture. You do not want to have your arms crossed, your legs crossed, and just appear to be unapproachable or resistant. You want to lean toward the client, and this shows that you are interested in what they are saying and that you are fully present. You want to make sure that you establish and maintain eye contact, which I believe I did mention the eye level, but I want you to maintain eye contact while they're speaking to you, unless there's some kind of cultural barrier there or the patient has some kind of deficit where they do not maintain eye contact with people, then you want to just discern that as well. And also, you want to appear relaxed. You do not want to appear as if you are uncomfortable with this conversation or uncomfortable sitting with this patient at this time, as if you do not have time to listen. You want to be present, you want to be relaxed, and you want to be open, leaning toward them, looking at them, and listening actively to them. Silence is another therapeutic technique. So silence allows the patient to gather their thoughts, especially when they need to make an important decision. It also allows them the power to initiate the conversation or restart the conversation when they feel ready to. So be patient, be willing to wait, be willing to sit in silence. Never rush the patient to respond. In addition to, you want to remember it is very important during grief and loss could be the loss of a limb, it could be receiving a poor prognosis, it could be the possibility of death or something such as hospice, where there is no treatment available for the patient. So these are all considered possible loss or grief situations. So allow the silence to remain until the patient initiates the break in the silence. So please do remember that. Communication skills. So touch is a communication skill. So touch is a powerful means of communication, the most highly developed sense at birth. Touch can connect people by providing information, reassurance, and stimulation. It can also decrease loneliness, increase self esteem, share warmth, intimacy, approval, and emotional support. It can also communicate negative feelings like frustrations and anger. Humor is a communication skill that can be learned. So your textbook suggests that you find a nurse that uses humor and study him or her so that you can learn this technique if you do not already have this technique. Humor can heal the patient as well as help develop relationship with the patient and the nurse. And humor helps the nurse and the patient reduce stress by releasing excessive physiological and psychological energy. And providing leads is also a therapeutic communication. It helps the client to verbalize their feelings and it steers the conversation. And it also indicates interest. So you do want to stay on topic and allow the client to stay on topic, almost like a tunnel vision. But you don't want to lead the conversation as into giving your opinion about how they should feel or what they should do. You just want to make sure if we're talking about this venous stasis ulcer, that we are on topic about things relevant to the venous stasis ulcer. And we're not talking about things that are not focused on the task at hand. Okay, hopefully that made sense. Nurse communication techniques. So we're going to speak about the nursing process briefly. I know we talked about this in class before. So add pi. So A is assessment. D is diagnosis, and that's a nursing diagnosis such as ineffective breathing pattern, right? Or at risk for falls, not a medical diagnosis such as a CBA or a heart attack or a myocardial infarction. So then we have P for planning. So planning, what is our ultimate goal? What are we planning to do for this patient to alleviate this problem or this nursing diagnosis, right? This problem or potential problem. So our planning is actually our goal. We're planning our goal. Okay. So the patient will be free from falls. That's our goal through the next 30 days. You always have to have a time frame. Then you have implementation. Implementation is just what are we going to do? What are the interventions we're going to put in place to make sure our patient can reach our goal? So the patient is at risk for falls. Our goal is for the patient to remain free from falls for the next 30 days. And then what are we going to do to help meet that? We're going to keep the bed in the lowest position, place a fall mat on on the floor so that the patient won't injure themselves in the event that they fall. We want to toilet them every 2 hours. We want to provide assistance as needed when ambulating to the toilet. And then E for evaluation. So now we're going to evaluate how did the interventions we implemented, how did they work, right? Were we able to keep this patient safe for 30 days, safe from falls and injuries for 30 days, right? So did we meet our goal? If we met our goal, then goal was met, patient remained free from falls. If we did not meet our goal, then patient fell on September the 29th and sustained no injury, added a bed alarm to the intervention. So you want to make a adjustment to the plan of care in the event that it was ineffective. All right, so SBAR. SBAR was talked about briefly in lab last week. I believe Ms. Gibson talked about it with you guys. So S is situation, B is the background, A is assessment, R is recommendations. And I know you have an SBAR that you're completing for your DocuCare assignment as well as your VSIM assignment. Then you have the ISBAR R. Okay, so ISBAR R is something that QSIN recommends. QSIN states that ISBAR R supports clear identification of the nurse and patient communication. So it's the same SBAR. However, I is where you identify yourself and ID your patient. And then the extra R is a time for the patient. It's a time to ask questions or to respond to questions, right? So you maybe give them a report and then they have questions. So what was the potassium level? And now you're responding. The potassium level was 3.5. And then if in fact that there's no questions and response needed, then this is the time to kind of just read back and close out this actual SBAR. So you can go back through your recommendations, a brief, the patient is doing this, doing that, doing this, and my recommendations is this. Make sure that your colleague clearly understands what needs to be done for that patient. I'll take a minute for any questions.